So this is a 50 years old male patient, diabetic hypertensive, presented with the inferior wall ST elevation MI within 2 hours of chest pain, and decided to do the primary angioplasty. And this was a radial approach, but you can see there is a lusoria, and could not engage the artery here. That is why we changed the approach to the femoral. So this was a left coronary artery. You can see there's a mild lesion in the L6 and LAD also. This is a iliacaudal view. There's a epicaudal view, and you can see there's a mild lesion in the proximal LCX. There's a epicranial view, and you can see the almost normal LAD. Is a areocranial view. And as expected, there is a thrombotic occlusion, total occlusions of the RCA in the proximal. So it is decided to do the angioplasty for this patient. So for this BMW PTCA, where it was a cakewalk and it crossed immediately. There's a BMW PTCA wire with a JR catheter. So proximally, we took a stent of 3 into 36, and you could see all thrombus is there. So this is a deployment of stent, and you could see there is a under deployment in the proximal part starting of the stent. And after stenting into the proximal part, you could see there is a under deployment of the stent, and decided to put a second stent in the mid RCA because of the thrombus everywhere. This was the second stent placement, and we wanted to plaster all this thrombus to the arterial wall. So this was the second stent in the mid RCA, and we overlapped the both stent, and then we did the NC for the first stent, and then you could see the 100% thrombotic occluded stent. After stenting, could see the wonderful RCA. There's a minor lesions in the distal RCA, but it has opened. And this is a cranial view, and you could see everything has opened well. And then we have given the tirofiban, Nicoran, everything, and patient chest pain has relieved. So this was the primary angioplasty to RCA, presented with within the 2 hours of chest pain, and TIMI3 flow we got.